Hello, my name is Jack, and today I will be teaching you about sleep apnea. So, sleep apnea is a common breathing disorder characterized by fleeting disturbances of breath during sleep. Apnea is the Greek word meaning want of breath, and then when you pair that to sleep, obviously it makes sense. It's discovered in 1965 by Colin Sullivan and William Guilleminot. They conducted these studies using a polysomnography, which is a technique that monitors various physiological parameters during sleep, such as breathing, heart rate, and brain activity. And this is meant to understand sleep apnea. So, the average night for someone with sleep apnea, you're looking at 20 to 30 or more involuntary breath pauses per hour. These pauses are often followed by snoring between episodes, and severe cases can lead to choking. Typically, they have headaches and daytime sleepiness when awake as well. And don't worry if you have snoring, it doesn't mean you have sleep apnea. So there are two types. Less common is central sleep apnea. This is when the brain stops transmitting the right neuromuscular signals to the breathing muscles to commence proper respiration. And then more common, you're looking at obstructive sleep apnea. This is most cases when air can't course through in or out the subject's nose or mouth, even though attempts to breathe continue to persist. So, who gets sleep apnea? Ladies, you're lucky. Most common in men, however, it does occur in both sexes and all age groups. There are roughly 18 million Americans who suffer from sleep apnea, 4% of all middle aged men, and 2% of all middle aged women. You're more likely to develop it if you frequently snore loudly, if you are obese, if you have high blood pressure, if you have a physical deformity or abnormality in the nose, throat, mouth, or the upper airway, and genetics also play a role in causation. So, sleep apnea can happen when the muscles of the throat and tongue relax while asleep and partially block the opening of the airway. So, the airway becomes blocked when muscles of the soft palate at the tongue's base and the uvula slacken, which makes breathing hard and noisy and can even completely stop. Sleep apnea also happens in obese people when excess tissue narrows the airway, so causes the person to keep trying to breathe, but air has trouble easily flowing in and out of the nose or mouth. This produces heavy snoring, intervals of no breathing, and recurring arousals. These sudden changes from deep sleep to light sleep are also common. And then intoxication of alcohol and use of sleeping pills can also cause sleep apnea as well. So, how patients breathe normally with sleep apnea. So, during an episode, you're going to have low oxygen and high carbon dioxide levels in the blood. This is caused because the individual can't breathe in oxygen or excrete carbon dioxide correctly. The change in chemistry signals the brain to continue breathing and create an arousal. When aroused, the brain creates a stimulus which is transmitted to the upper airway muscles, which allows the airway to open. Accompanying this is a heavy snore or wheeze, and these recurring arousals prevent productive deep sleep, even though the arousals are required in order to resume proper breathing. So we can look at this graph, progression of sleep apnea, and it kind of just shows us that on our risk modifier side, hypertension, obesity, and systemic inflammation all lead to atrial fibrillation. And then if you look at hypertension, that one can also lead to ventricular tachycardia and sudden cardiac death. And then our acute triggers, for the most part, all lead to atrial fibrillation. However, respiratory effort during obstruction can lead to sinus node disease, and then intermittent hypoxemia and hypercapnia, as well as intrathoracic pressure alteration, can both lead to ventricular tachycardia and sudden cardiac death as well. And then here's a continued chart for the progression of sleep apnea. So AHI stands for Apnea Hypopnea Index. We'll get in depth with that a little more later. However, when you see 5 to 14 cases of that, that's mild. Moderate, we're saying 15 to 30, and then severe is anything that is over that. So some symptoms of sleep apnea include depression, irritability, sexual dysfunction, trouble with memory and learning, falling asleep during the day, especially at weird times like driving a car, working, or even holding a conversation with someone, and then high blood pressure, loud and heavy snoring, difficulty breathing in the night, and a really common symptom also is like the patient might not even know they have it or might be in denial about it. So sleep apnea diagnosis includes polysomnography. I know we got a little bit into that, but just to reiterate, it's initially used to find the first case of sleep apnea. It measures multiple bodily functions when sleeping, and the test can show if you have sleep apnea or not, and it can pinpoint how severe the case actually is. And then the other diagnosis that we use is multiple sleep latency test, which measures how fast it takes for you to fall asleep. That patients are given various windows to fall asleep in the day when they're supposed to be awake usually, and are measured at how long it takes to fall asleep. A normal person takes 10 to 20 minutes, and we see sleeping problems usually when it takes 5 minutes or less to fall asleep. So this test can also measure daytime sleepiness and how severe that is as well. And we have a few graphs here that take a look at the effect of sleep apnea on exercise response. So like I said, AHI is apnea hypopnea index. So it's the metric used to measure the amount of breathing disruptions or apneas per hour when asleep. So if we look at a normal adult, they obviously experience 0 AHI, but when they exercise every minute per week, it decreases that chance. So we can see 70 minutes around gets negative 14 AHI, which is really good and kind of shows that sleep apnea can be cured by exercise. And then I found two other graphs as well that kind of reiterate this point. So the one on the left shows a mean difference in VO2 peak and kind of just shows us that exercising increases that, which we should know. I mean, we're seniors in exercise science field. And then the other graph shows the mean and difference in ESS, which is the Epworth Sleepiness Scale. And that measures how much daytime sleepiness. And you can see that as we increase the minutes per week that we're exercising, we're actually decreasing the amount of daytime sleepiness we have, which is a huge symptom of sleep apnea. So management and medication, what can we do? There is no treatable medication for sleep apnea. Oxygen administration might work for some people. However, it doesn't fully get rid of that sleep apnea or the daytime exhaustion. Behavioral therapy can sometimes be enough to treat it, like avoiding alcohol or tobacco, avoid sleeping pills, lose weight if you're obese, and stop sleeping on your back or use a pillow. The way you sleep can actually affect if you have it or not. So back sleeping, try using a pillow or sleeping on your side might help. And then physical or mechanical therapy may be needed, or sometimes even surgery in really bad cases. So the physical and mechanical therapies for sleep apnea include a nasal continuous positive airway pressure device, which is a mask over the nose that forces air through the nose. There are side effects such as nasal irritation, skin irritation, bloating, mask leakage, sore eyes, headaches, and more. And then dental appliances. They say these work, but they sometimes lead to teeth, tissue, and jaw damage, but usually supposed to just open the airway. Surgeries for sleep apnea. I'm not going to get into these too much. I'm going to take a while pronouncing these. So, uvulopalato-pharyngeoplasty, laser-assisted uvulopalotoplasty, and tracheostomy are all different surgeries that can help with sleep apnea. And so we're getting into my case study now. So Ryan is a 45-year-old male who suffers from obstructive sleep apnea. His BMI is 30, so he's obese, and he manages his sleep apnea with a nasal continuous positive airway pressure device. Ryan also has mild pain in his lower back and suffers from hypertension, which he takes an antihypertensive for. Ryan lives a sedentary lifestyle and has previous family history for heart attack. Medical clearance is recommended for Ryan to partake in exercise. His goal is to get off the couch and get active more. He wants to put on a bit of muscle and lose some of the fat that he's accumulated. Also, he wishes to improve his heart health since he's at risk of heart attack, as well as improve his quality of sleep and reduce his daytime drowsiness. So in the exercise testing department, for aerobic, I did the 6-minute walk test because patients suffering from sleep apnea often have poor cardiovascular and respiratory fitness because of their reduced oxygen saturation, which is caused by sleep disruptions. This test intensity is light enough to not overwork Ryan. And then for muscular fitness, I chose the hand grip dynamometer test. just because it's a simple and effective way to measure strength for patients with sleep apnea, especially since reduced hand grip strength accompanies other symptoms for patients suffering from obstructive sleep apnea specifically. And then for flexibility, I did the shoulder flexibility test because uh, it's good for patients with sleep apnea. It's great. It's a great evaluation of posture, muscle weakness, and upper body tension, which are all issues which can obstruct a narrow the airway and can contribute to obstructive sleep apnea. And here's my exercise prescription. So the fit principle for each of the three. So for aerobic, I did 4 to 5 days a week, muscular fitness 2 to 3 days a week, and then for flexibility, I said daily. The intensity we have here, aerobic, I said moderate, so around 40 to 60% of that VO2 max. Muscular fitness, moderate, 70% of your 1 rep max. And then flexibility, I just said no pain, just to mild discomfort. And then our time for each aerobic, 15 to 30 minutes per session. Muscular fitness would be 6 exercises, 3 sets of 10 to 12 reps. And then flexibility, I'd say 10 to 15 minutes per session. And then our type for each. So we'll be doing walking or cycling, weight training with grip work, and then static stretches and yoga, which we're going to be targeting the shoulders in to help with that posture. And here are a few precautions or modifications that I would include in Ryan's plan. Exercise might improve Ryan's tolerance to the nasal continuous positive airway pressure device, so I promote conformity to using it more. To avoid daytime fatigue, I'd set the workouts earlier in the morning rather than in the evening, just to help Ryan out a little bit. I'd also make sure to track Ryan's sleep and his quality of sleep. And I'd also track his AHI changes over the course of his exercise program. Slow and gradual increase in intensity and progression to prevent overexertion. And then obviously I'd avoid, like overheating, make sure Ryan is hydrating the right way. And then I'd make sure all exercises are comfortable, and I would modify those that aren't, so we can avoid mobility issues and joint pain, especially since he's obese and has postural issues. And then this is my favorite part. Like my key takeaway from this presentation is to understand that people suffering from sleep apnea sometimes don't even know that they have it, or they'll deny it. Like I said earlier, I chose sleep apnea because I believe that a family member of mine, who I'll just call a family member, is suffering from it. And I wanted to gain more knowledge on it to see if I was right on that. Um, because sleep apnea really does um, pay a huge dividend on day to day life. And more activities become difficult that were once simple. So this disease usually is preventable and it's chronic. And if it's chronic, there are ways to make sleep better. So all I say is, like, if you think someone in your life suffers from sleep apnea, it can never hurt to take them to the doctor that specializes in it, because it can be life threatening. And then if you're wondering, based off of all the research I've done, I do believe my family member has sleep apnea. And the irony of it is he is denying it and doesn't believe it. Before I've even shared this presentation, but I think I'll do a little thing with him and sit him down and be like, "Hey man, like I think you have it. So here's my evidence." And I did a slideshow for school. So that was kind of my motivation to do sleep apnea for this project. And here are my sources. I hope you enjoyed my presentation and have a wonderful rest of your day.